Welcome, everyone, to Menopause Illuminated. I'm Janet Coe, President and co-founder of the Menopause Foundation of Canada. We are delighted to have so many people joining us from coast to coast to coast, from every province in the territories. And we're really joining forces together to close the menopause knowledge gap, to make sure that we have the information we need to thrive at what is truly a wonderful stage of life. I'm very pleased to introduce my colleague, Jennifer Arnott. She chairs the Foundation's communications activities, and she's going to help us tonight in the background with the Q&A. She'll also read the all-important land acknowledgement. Over to you, Jennifer.
Thank you. The Menopause Foundation of Canada acknowledges that we live and work on the traditional territories of First Nations, Inuit, and Métis peoples who have cared for this land, now called Canada, since time immemorial. We recognize land that is shared through historic treaties, developed through contemporary treaties, and land that continues to be unceded territory. We are grateful to those peoples who have come before us and those who live and work alongside us now. Thank you.
Thank you, Jennifer. We'd also like to thank this session for our sponsorship, generous sponsorship from Pfizer, making it possible to bring this program to you. And without further ado, I would like to introduce our Menopause Illuminated trusted expert, Dr. Michelle Jacobson. It's really my honor to share with you some of her credentials. She is one of Canada's top OB/GYN menopause specialists. She has dedicated her career to women's health, and she's very passionate about this area. She has worked in some of the top hospitals in menopause clinics, and she just recently started her own women's health organization called Coven Women's Health. She is often described as the doctor that other doctors call when they have a challenging case related to menopause. And she specializes in treating women experiencing menopause due to cancer or those with hereditary breast and ovarian cancer syndrome. She serves as a board member of the Canadian Menopause Society. She's on our medical advisory board. She drafts some of the guidelines for menopause care in this country. So as you can see, we are in very good hands to be guided in this conversation. So welcome, Dr. Jacobson.
Thank you, Janet. It's really my pleasure to be here.
Yes, it's so great to have you. We're going to start off with hopefully shifting the narrative a little bit about menopause. Menopause is so often viewed through a negative lens. The image of the woman in menopause is often very unflattering. And I know that you share my passion for changing that conversation and really seeing this as the prime of a woman's life when she's really coming into her own. Can you perhaps give us your thoughts on how we should look at menopause and why you think this is a great time of life for women?
Absolutely. I mean, menopause is a liberation, if you ask me. This is a time where you no longer need to be worried about getting pregnant accidentally. You don't need to be worried about getting a period unexpectedly. Instead, you can really, I think, embrace the idea that you are your most powerful, which is a bit of a throw out to Coven because we believe that women who are the most interesting would probably have been the witches of the 1600s and would have been burned right at the stake. Those are the women that we think are going to be their most exciting and their most powerful in menopause. If society feels that aging women are not interesting anymore, they, I think, have a real change coming. Because look at people like yourself, like the people who are advocating for menopause across the world. We are women who are coming into our own and have way more to say and care way less about what everybody else has to say about that.
So well said. So well said. Let's dive in. The first half of Menopause Illuminated is going to focus on the questions that we received, hundreds of questions that we received from people who submitted them. And the second half, we will go to the live Q&A, and everybody can use the Q&A function for that. As a reminder, Dr. Jacobson cannot answer specific health questions, and we really encourage you to find a qualified healthcare provider, but she will respond in general and in depth to as many questions as possible. So the first theme, one of the biggest areas of focus where people sent in so many questions, was related to perimenopause. there's still a lot of confusion about what perimenopause is. Let's start at the beginning for people. Can you clarify what perimenopause is? Why is it so unpredictable? When does it start? When does it end? What are the classic symptoms? And I know there's now conversation about there's an early perimenopause and then there's late perimenopause. And are the symptoms different in early and late? If you could talk to us about that, and then maybe we'll get into solutions and treatment options.
Absolutely. Perimenopause is a really challenging time because there are no rules when it comes to perimenopause. It can start at any number of years leading up to when the final menstrual period will end up being, but the symptoms can be quite confusing and insidious, especially when women are still getting their periods. So if you're still getting a period, whether it's coming regularly or more frequently, or spacing out. If you don't have the obvious symptoms of menopause like hot flashes and night sweats, it can be very hard to understand why you don't feel like yourself. And in retrospect, we can often say, oh, yeah, that was perimenopause. Just like for women who might say, I don't know why I'm in such a terrible mood. Then they get a period. They say, oh, I guess I was PMSing. Perimenopause is a bit like that as well. You don't always realize what's going on until you can look back and say, I was getting closer and closer to menopause at that time. So what we think about when it comes to perimenopause is that the amount of ovarian function is decreasing, and your brain is still making a hormone to talk to your ovaries to tell them to make an egg. So early on, while there still are some eggs there, the eggs get produced, but they're poor quality. And so we end up getting ovulations that happen in a less cyclic pattern, where next ovulation can happen before the period from the preceding ovulation. So people will feel like they're PMSing all the time. They might have sore breasts and bloating and anxiety and moodiness and fatigue and trouble sleeping. And if they're lucky enough to get hot flashes and night sweats, it might be very obvious to them what's going on, but otherwise they just don't know why they don't feel well. And this issue of I don't feel like myself, which is such a common thing women will say in their late 30s or early 40s as they're entering perimenopause, has been studied. And we now understand that it can be associated with a variety of symptoms, all of which are the classic perimenopause ones: poor sleep, anxiety, rage, irritability, depression, low libido, fatigue, muscle aches, and joint aches. And all of this continues on into menopause, where there's no clear beginning and end, because you would only know when you made the 12 months into menopause, once there's been a year without a period, if you're someone who gets a period. But up until then, early perimenopause is going to be when you're still getting periods fairly regularly, but you're starting to feel not as well, or you're like yourself. And late perimenopause will happen usually 2 or 3 years prior to when your final menstrual period would have been. And that's where it's more common to see your cycle spacing out. You might get gaps of 60, 90 plus days between periods. And in that time, when estrogen levels are quite low, the symptoms tend to be more obvious.
That's such good information. I know so many women who report that not feeling like themselves and being very confused about that. And I think it's very good for women to understand that they could have different symptoms at the beginning of their perimenopause than at the end. I know for myself, I didn't have hot flashes until the very end, towards the end, but I had all of these symptoms at the beginning that I just had no idea were part of this menopause transition. Let's shift into what women can do about their perimenopausal symptoms. And we did get a number of really great questions that came through. Women asked during perimenopause, their doctors are suggesting putting them on birth control pills or hormonal IUDs versus starting on menopause hormone therapy. They would like to know why their doctors are asking them to do that. Is this a good idea to do that or not? Some women are told they can't start hormone therapy until they actually reach menopause, and they want to understand if that is true, if they can start before they reach menopause, and what are the other options that women have. And for those who do not want to take any medications at all, what is available to them? So treatment options so that women have choices.
I think we need to do a whole nother Menopause Illuminated about this, because that was 42 questions in one, and it's absolutely true. That's how perimenopause feels, right? The most important thing at the end of the day is that the woman feels better with regards to her symptoms. And that's why there is not a one-size-fits-all approach where there is a recipe that we can use to treat all women to fix all the symptoms of perimenopause or menopause. It has to be so individualized. So when doctors are suggesting things like birth control pills or IUDs, that could be for two reasons. One is, like many physicians, they were trained and told that hormone therapy and menopause management should only be used once a woman is in menopause and is a year from her final menstrual period. Certainly, this is a very outdated way of thinking. It's not that they're out to get you and they're trying to gaslight you. It's that this is what they were taught. And a lot of what we do, even in settings like this, is try and teach that the symptoms of perimenopause and menopause are similar, and the treatments, therefore, are also similar. There is certainly no need to make a woman suffer for a year to prove that she's menopausal. And not everybody reads the same textbook. Practically speaking, there's no difference between a woman who's suffering for 9, 10, 11 months or 13, 14, or 15. And for someone who's had a hysterectomy where their uterus was removed, you may not even know when their final menstrual period would have been. So she gets treated because she's symptomatic with no periods, but other people have to wait? Absolutely not. That makes no sense. Now, the other reason that you may be offered hormonal IUDs or a birth control pill is perimenopause is really complicated, and I like to think of it as three horsemen. The three horsemen of perimenopause that we still have to think about are abnormal bleeding, which is very common as you approach your final period, the need for contraception, which is often very different for some women in their 40s and beyond than when they were younger, and the need to treat the menopausal symptoms. And not all women will share these three horsemen, but for some women, all of these things have to be taken into consideration. So for some who are having heavy, unpredictable bleeding, who need contraception, and who need their menopausal symptoms treated, all of that could be accomplished with certain birth control pill regimens. And that's why it makes a lot of sense to consider it. For others, something like a hormonal IUD plus estrogen replacement could also be a good way of achieving contraception, cycle control, and menopause symptom management. But for the women who don't have the two horsemen and just have the menopausal symptoms, the approach to treatment should be very similar to it is for a woman who's already in menopause, where we would treat her symptoms, whether it's her sleep, or her libido, or her hot flashes, or her vaginal dryness, with the right treatment to treat those symptoms.
This is so useful. So we need to think about birth control, contraception as an option, particularly for those women who have heavy bleeding and who need contraception. So in some circumstances, it's a good thing. And then we have to break that myth that you can't have hormone therapy until you actually reach menopause. Not true. We can have access to it before then, and it's very appropriate. So that's really helpful. What about for the women who either don't want to take hormone therapy, can't take hormone therapy? Are there other non-hormonal options available? And are there non-prescription options that are available to women to manage through some of the symptoms that they're having?
Absolutely. And again, this falls into the umbrella of what symptom are we trying to treat with you? So if your biggest symptom is that you're irritable or you have a low mood or anxiety, you're going to benefit either from hormone therapy or from a combination of mood medicine and therapy, cognitive behavioral therapy, interpersonal therapy. And it's possible that you would benefit the most from all three, but it's also possible that only one of those options is going to be enough to help your mood. If sleep is the problem, we have to understand more about your sleep. Do you have trouble falling asleep? Do you wake up in the middle of the night because of a night sweat? Do you wake up to pee? Do you just wake up and you can't fall back asleep because your mind is racing with anxious thoughts? Or are you just wide awake with an empty mind and you can't fall back asleep? And then you get more anxious the next time you go to sleep that this might happen again. So we can ask all these questions about specific symptoms to understand what it is that's bothering you the most, and then come up with a really individualized plan, which may include a change in the way you're eating, a change in the way you're exercising, a change in your habits with regards to sleep hygiene, using your phone in the bedroom, exercising at night, caffeinated beverages, the amount of liquid you take in, versus non-hormonal, non-prescription therapies like certain supplements or soy products, which can sometimes be helpful, melatonin, magnesium. This might be really helpful for sleep. Or we can move into the world of prescription therapies, which are non-hormonal, but are again meant to address the symptom at hand. Do you need something for anxiety? Do you need something for sleep? Do you need something that is going to treat your vaginal dryness because you're waking up to pee so often? So there is no one size fits all approach, especially in perimenopause when women are so complex and their needs are so unique.
I think tracking our symptoms seems to be so important so that we really understand what is happening to our own bodies and we can have that conversation. We're getting questions coming through about, how do you know when you're actually in menopause if you've had a hysterectomy, if you don't have your regular periods? What's the answer to that one, Dr. Jacobson?
The answer is you don't know when your final period would have been, but you know when you are in your menopausal transition because you are symptomatic. And blood work, which can sometimes be helpful for younger women who are having menstrual irregularities, is not that helpful for diagnosing menopause because our blood work just tells us what we already know, that you have less eggs left in your ovaries than you did before. That is really what the reflection of your brain hormone talking to your ovaries is. I think of it as the higher that brain hormone is, the louder your brain is yelling at your ovaries to make an egg. And if your ovaries don't respond because they don't have an egg left, then that brain hormone goes higher and higher. But that could be true for someone who is still in her late 30s or early 40s, who is still capable of becoming pregnant, whether she wants to or not. We can get a snapshot in time of the brain yelling at an unresponsive ovary, and the next day we can get a follicle recruited and a ton of estrogen being produced. So the blood work is not that helpful for diagnosing menopause in an average aged woman who is making her way through her transition, but it's also not important because what's important is your symptom. And if your blood work is not reflective of your symptom, I'm still going to want to pay attention to you and your symptom rather than what the blood test shows.
Mm-hmm. And just so everyone knows, we have an updated menopause symptom tracker that's available at the MenopauseFoundationCanada.ca. And that was endorsed by the Canadian Menopause Society. And that symptom tracker is created by members of our medical advisory board, like Dr. Michelle Jacobson. So you can have a high level of confidence that you're tracking and really looking at the key validated symptoms of menopause. Okay, we're
so important, right, Dan? I'm sorry to interrupt you, but sometimes you can't think of everything when your doctor asks you or when you're thinking about your symptoms, to have that inner reflection to say, this is menopause and this isn't. So the tracker that you guys created with our endorsement, I think it's so valuable because it gives women some context and a frame of reference to look at this and say, hey, I have that and I have that too. And I didn't know that that could be menopause. And when you have that there and then you're tracking it in an objective way, when you go to seek treatment wherever you're going, you actually have some context and content to back up the way you're feeling so that you, again, minimize that experience of being gaslit or your symptoms being pushed away.
And it's also our way of helping our physicians who are so stretched, to have better information going in so they can then have better information to support us. The second theme tonight that came up, lots and lots of questions, not surprising, on hormone therapy. The when, the why, the how. I think people really want to have clarity around the risks, the benefits of hormone therapy. And I know, Dr. Jacobson, you have actually written materials that have been published in key medical journals talking about modern menopause management. Could you give us a bit of a primer on hormone therapy? What can it actually do for us? What is it indicated for? What are the benefits? And who are the people that probably shouldn't be looking to use it? What are the contraindications? That would be really great. As you know, if people are on social media right now, there's a lot of noise about hormone therapy, almost like it's a magic bullet to solve all of the problems that we may have at this stage of life. So would love to hear your perspective.
Yeah, and I really am grateful you're asking because that misinformation out there is so cruel to women who can't or shouldn't take hormone therapy, because it makes people think that they've missed the boat or that they're less than or not going to be getting the treatment that they need because of something that has happened to them in their medical history. And that is A, not necessarily true, and B, there are ways that we can still mitigate risk. So in its simplest form, hormone therapy is a combination of hormones that includes something like an estrogen and something like a progesterone. We'd call it a progestogen, or a similar type compound that protects the lining of the uterus from the growth that it will have in response to estrogen. For the most part, the estrogen is responsible for treating many of the symptoms of menopause, although some women get benefit from different types of the additional hormones as well, like certain progestogens or testosterone. But when we're talking about menopausal hormone therapy, we're usually talking combination estrogen and progestogen for a woman who has a uterus. And there are many different ways that this can be prescribed, with the estrogen being taken orally by mouth or through the skin through a patch and a gel, or the progestogen, which can be prescribed again by mouth or vaginally or through an IUD, and in certain circumstances through the skin, but not all. I'm going to take a quick caveat to say progesterone should never be applied on the skin because it doesn't get absorbed adequately, but there are synthetic versions that can be absorbed through a patch form.
Can I just pause you there,
please.
Dr. Jacobson, because I think that's such an important point on the progesterone, that some women are getting progesterone offered at different clinics as a cream through the skin. And, it's so good to hear you say that's a hard no, do not do that because it may not absorb properly.
And it may not give you the cancer protection that the progestogen is supposed to give you. So this is a really important point. And again, it lends itself to that issue of misinformation out there. When it comes to hormone therapy, it is primarily the estrogen that is going to be impacting the symptoms. And the thing we can hang our hat on is that for most women, estrogen will treat hot flashes and night sweats. And technically in Canada, that is the reason that we are supposed to use it for. In other places in the world, the same compounds, the same estrogens are meant to do other things. So we can extrapolate and say Canadians can be just like Americans or Europeans, and taking estrogen will also help to protect against osteoporosis, which is one of the American indications. And if you look at the International Menopause Society, they give very broad reasons to consider trying estrogen. They say, for the most part, estrogen can help with many of the symptoms of menopause that are on your validated list. And so it's worthwhile to try them to see if your mood improves or if your arthritis and your joint aches improve. Certainly locally, we can use estrogen or other hormones to treat vaginal dryness. So this is also going to be an effect. But it is first line, supported by all guidelines out there for the treatment of hot flashes and night sweats. It is not the fountain of youth. It is not meant to keep our skin supple or our hair thick or that perimenopausal weight gain around our abdomens. It would be great if it did, but reliably, that's not what it does. It doesn't necessarily fix brain fog, but it can fix sleep for many women. And that is probably the most important thing that hormone therapy can do for you. Because if you're not sleeping day in and day out, you are going to decompensate and have worse memory and worse cognition and more word finding difficulties and lower energy, and not be able to go to the gym to lift those weights, to reduce your body fat and to strengthen your bones. So focusing on what is going to improve our sleep the most is one of the hallmarks in menopause management, and hormone therapy can certainly help with that too.
That's great. So it's definitely gold standard vasomotor symptoms. So hot flashes, night sweats. It can protect your bones. It can be supportive on the other major issues of menopause. So for some people, it's worth it to give it a try and see if it
have a
works.
contraindication. Yeah, absolutely. For some women, they'll say that fixed my mood or that fixed my brain fog. Others will come back and say it didn't fix that. And I think setting expectations is really important. Reliably, hormones should be used for vasomotor symptoms, which is hot flashes and night sweats, but it can make women feel better in many different ways as well.
And then can you speak to risk reduction? I've read that it can reduce your risk of type 2 diabetes, reduce your risk of cardiovascular disease, not prevent, but reduce the risk if started within 10 years of reaching menopause. So can you speak to some of those additional long-term health benefits?
Yeah. So while it's not a primary preventive agent, which means you wouldn't take it like you would a vaccine to prevent shingles, you don't take estrogen to prevent cardiovascular disease. But studies that look at women who started hormone therapy close to their menopause have shown less cardiovascular changes that are negative over time. So we can expect if you start hormone therapy close to the time of menopause to have less plaque formation in the blood vessels as you age. But if you already have blood vessel plaque and you start estrogen, that can cause little pieces of the plaque to break off and cause heart attack and stroke. So there really is a fine tuning or a balance in terms of when you start hormone therapy and the future expectations you can have from it. And one of your questions, Janet, was about who shouldn't take hormone therapy. And, they often, I think, get the message out that they've missed it or that they're worse off because they can't take it. And I think that's why it's really important to remember that the reason we should take hormones is to treat hot flashes and night sweats. And if we can't take hormones for that, there are alternatives that work very, very well. And that hormones are not supposed to be used for all of the other things that you can read out there that it gives benefit for. And so the primary reasons that women wouldn't be able to take hormone therapy would be if they had a history of certain types of estrogen dependent cancers. A lot of the time, that's going to be any kind of breast cancer, including estrogen receptor negative breast cancer, certain gynecological cancers, among others. Now, again, this is not one size fits all. There are always going to be individual approaches, and sometimes you need somebody with some expertise to help navigate your own decision making and the data that's out there. But for the most part, if you are seeing a primary care practitioner, like a nurse practitioner or a family doctor, they are usually not going to prescribe hormone therapy for someone who has had breast cancer, a blood clot in the legs or the lungs, or a stroke. There are some other nuanced reasons women should avoid hormone therapy, but those are the biggest ones that tend to impact women.
We also got a number of questions just about natural options, so-called natural options to manage menopause. Can menopause symptoms be managed by taking herbal supplements? Does black cohosh or red clover work? There are many advertisements out there for supplements to balance hormones and take care of my menopause symptoms. Do they work? And we, of course, know that, women are now being marketed to. This is a multi-billion-dollar market. So there's all kinds of advertisements that are hitting us, telling us that everything under the sun can actually support us. So maybe you could respond to some of those questions.
Absolutely. And it's so important because we don't deserve to be taken advantage of, right? We're at this point where we're needing treatment and therapy. And for you to be spending money on something that is not going to work is a huge insult to your intelligence and to your worth. So knowing the evidence out there, I think is really valuable. The other caveat that I would put in here is that when we look at studies that compare menopause medications or supplements to placebo, those studies are going to look at the population, right? The whole group of women who were tested, and they're going to say, on the whole, this happened or that happened. But on an individual basis, some women have a better experience with certain supplements than others. So if something isn't dangerous and you want to try it, it's probably very reasonable. But if we look at studies that compare black cohosh, red clover, wild yam, evening primrose oil to placebo, they have not been shown to be more effective than placebo. If for you they work, it's very reasonable to continue taking them. But hormone therapy, non-hormonal prescription alternatives, cognitive behavioral therapy, hypnosis, these are the things that have actually been shown to be more impactful than placebo at treating hot flashes and night sweats. None of the other supplements can say that, but I still think if they give you relief, it is reasonable to use them.
I really like how you frame that, Dr. Jacobson, because we are all unique individuals. And I've talked to many women who take a certain supplement and feel it's really helping them. And if it's helping them, that's great. Continue to take it.
The placebo effect in menopause studies is usually around 40%. So that means that if you've got bad hot flashes and you are in a study and you take the placebo, 40% of your symptoms will improve, even though you're taking nothing at all. So if you can achieve that with a supplement and you're okay with that, more power to you. That's great. But it is not going to work for everybody. And it's not evidence-based. Evidence-based means it has that trial data behind it showing that it is better than placebo.
For sure. And we don't want, to be wasting our money on things that actually don't have the evidence behind them. I know I'm somebody who tried everything under the sun. And, for like a month, I thought, oh, maybe I'm feeling better. And then I really wasn't feeling better. And it wasn't until for my personal journey was trying hormone therapy and it worked. It was a game changer for me. It's not the solution for every person. So it's really an individual journey.
Absolutely. And we don't want to see women suffering and spending a lot of money trying things that have not been shown to work, right? Try things if it makes you happy and it's working, great, but don't wait forever because you deserve to feel better.
We're going to move into our final theme before we get into the Q&A section. And it's not surprising. We had many people submitting questions about surgical menopause and also some questions about early menopause, given your background. These were really heartbreaking kind of questions and stories that they were sharing. They described symptoms hitting them like, a freight train. A woman writes, I had to stop HRT because of hormone positive breast cancer. I have brutal menopause symptoms. Is an antidepressant my only option? Another question, I've continued to suffer from hot flashes 23 years after a hysterectomy. Is there a non-hormonal solution for me? So maybe you could answer those questions in that theme of surgical menopause.
Absolutely. Surgical menopause is hard because if you are premenopausal and then you have your ovaries removed, this is an abrupt and not a natural menopause for you. It tends to be more severe in terms of symptom burden and it tends to last longer. And there can be other health considerations like higher rates of osteoporosis and Alzheimer's dementia that go along with your menopause starting too early, usually before 40 or 45 years of age. If you have no contraindications, hormone therapy should ideally be started right away. But if you do have contraindications, like our case of our woman who was diagnosed with breast cancer and had to get off of her hormone therapy, then we need to focus on two areas. One is treating your symptoms, which if they're hot flashes, antidepressants are one option, but we have an entirely new class of medications called the neurokinin antagonists that work in the same place in your brain as estrogen does to treat vasomotor symptoms, hot flashes and night sweats. And what's incredible is they work as well as estrogen does in studies. So when they're compared, they work just as well because they're working in the same way that estrogen does, but without the risk of breast cancer recurrence in a situation like this. So it's really important that, again, you're seen by somebody who understands what the options are and you're offered the gamut of options, which include antidepressants, this neurokinin antagonists, an anticholinergic medication called oxybutynin or gabapentin, all of which can be helpful and again, individualized to your own symptoms in your own way. And also, on the other hand, some women with contraindications like breast cancer choose to take hormone therapy. And women who are adults and cognizant and able to make their own decisions should be able to weigh the risks and benefits of a treatment and understand what they can expect in terms of value and of benefit and what they have to take into account in terms of risk. So to me, nothing is off the table. You just have to understand the risks and benefits of using a given treatment.
I'm so glad you said that because I also believe that women should have the agency to choose what is right for them and to weigh those risks and benefits. Because we do hear from women at the foundation who talk about these symptoms that are just ruining their lives. And they are willing to take, a medication that's going to help them with that, knowing that there is a small risk of recurrence. So I think women really do need to have that agency to make choices that are right for them. We always suggest when you do have some of these more complex cases, it's really important that women see a highly qualified menopause specialist who understands all of the complexity and the nuance. I think what we're hearing from you tonight, Dr. Jacobson, is that we're all unique and that there can be some complexity. So, don't give up. Make sure you're getting the care you need. We are now going to move into the Q&A portion. We've received a number of questions here this evening. I'm going to start off with questions related to the genitourinary syndrome of menopause. to genital, urinary, and sexual health. So some questions that we're getting: is vaginal dryness normal? Is vulvar itching common in perimenopause? Will it go away? It is affecting my ability to sleep and do things that I love.
Great questions, and such an important distinction to be made here, because all of the symptoms you just described, itching, dryness, changes in sexual function, bladder urgency, this all falls under the umbrella of the genitourinary syndrome of menopause, which is how the changes in sex steroids impact the lower genital and urinary tract. But there is such a difference between vulvar itch, which is the skin leading up to where the mucosa starts, versus inside the vagina having a problem, which is where the tissue used to be wet and feels a little bit different than skin. And, anatomy is important here, and most of us don't know the right terms for our anatomy. But when you're describing something to, again, your physician, it's important that you use the right words to describe where it's happening. So an itch on the skin can be related to menopause, but it could also be due to a variety of skin conditions or reactions to pads that you're wearing, or sweat that's trapped in your clothing after exercising, or cleaning solutions that you're using that you bought because it said it was the right thing for your genitals, when you don't really need to be using any kind of products like that on your genitals, versus vaginal dryness, which is where your own tissue has stopped producing the moisture and you lose those invaginations, which are folds in the vaginal tissue, which are meant to be there to help the vagina stretch, accommodate birth, or insertion of something for sexual pleasure. So they are different and they can have different causes, but all fall under the umbrella term GSM when it comes to those symptoms. And the good news is, for the most part, these symptoms can be very easily treated. We can treat the vagina, the vulva, the lower urinary tract by putting hormones right there. Instead of needing to take it by mouth, we can apply hormones vaginally or onto the vulva, whether it's a cream or an insert or a ring or an ovule, that's going to deliver estrogen and sometimes testosterone therapy right to the vaginal cells and allow them to be renewed, because the old ones slough off, and you can get these changes in the vaginal tissue and the vulvar tissue that then make the vagina act and feel more like it did premenopausally, without any of the risk or benefit of taking hormone therapy by mouth or through the skin. And this can be started at any time. The rules or concerns about waiting 10 years and then not starting hormone therapy do not apply to the vagina and the vulva. This is a chronic, long-term condition. Treatment should be started as soon as symptoms are bothersome and should be continued as long as you want them to keep them at bay.
This gets progressively worse over time, and this is something that women really don't know or understand. I think another associated topic to this is using vaginal moisturizers or lubricants, which may help you feel better, but that's not addressing the underlying issue. Is that correct, Dr. Jacobson?
That's correct. You almost need all three for very severe disease. Although for women whose symptoms are isolated only to the sensation of dryness, sometimes moisturizers can be helpful. So moisturizers are meant to do exactly that, draw moisture to the tissue. So for women who've got dry skin, something like Vaseline or coconut oil or hyaluronic acid can provide moisture and keep moisture locked in, which can give an improvement to their symptoms. But it's not going to actually change the composition of the cell. For lubricants, we're talking more about high friction events. So typically something like intercourse, whatever you're inserting inside your vagina, are going to need a lubricant to help decrease the amount of friction so that you don't tear your skin and it's not painful. And so even women who are using treatment for GSM, like a vaginal estrogen treatment, can still use a lubricant for those high friction events to make them A, more pleasurable, and B, safer.
So vaginal estrogen, we can use that at any time. It's not systemic. And it can also help to prevent UTIs.
Yeah. So the treatment for the genitourinary syndrome of menopause is applying hormones locally, whether it's cream, a ring, an ovule, or an insert. There's also one tablet you can take, which is a treatment for GSM. It's not systemic hormone therapy. And the purpose of doing this is to treat all the symptoms of GSM, which could be urinary, like peeing frequently overnight, or urgency, or not emptying your bladder completely, or urinary tract infection. It could be the sensation of dryness or itch or abnormal discharge, and it could be the sexual function concern.
Could you speak to testosterone usage? We've received a number of questions about whether that is helpful for sexual function, but also helpful for cognition, for strength and muscle development. Could you speak to that, please, Dr. Jacobson?
Absolutely. And this really, again, falls under the category of what does the evidence say versus how do women feel? And they're not always the same. So, unfortunately, in Canada, and for the most part elsewhere in the world, other than certain countries, there is no testosterone product that is approved for use in women, which means if we prescribe testosterone, we prescribe it as a product that is available for men in a dose that is more appropriate for women. This is called off-label or not Health Canada approved, which again is fine. We do off-label things all the time if they help to treat our symptoms. So testosterone has been shown in studies to improve libido, which was measured really inappropriately as the number of times you have a satisfying sexual event in a month. And I think most of us would agree that that's a terrible way to measure how much somebody wants to have sex, the number of times they actually had sex. So the truth is we have very poor data on sexual function in women, especially in women who are aging out of their ovulatory years. So testosterone was shown, if you apply it through the skin in doses appropriate for women, to help with the number of times those women had sex in the month, but it was never shown to improve things like energy or muscle building or cognition. And yet many women who start it for the low libido will also note improvement in some of those other symptoms. So again, I sort of take the approach as to say, if you have no reason to not use it and you're able to use it safely and in a monitored fashion, because we check blood work while you take testosterone, that it's worth a try to see if it improves some of your symptoms. And if it does, that's a win. And if it doesn't, at that point, you would stop it. But because some of the side effects from testosterone can be irreversible, like voice deepening, male pattern hair loss, and growth of the clitoris, where it can become almost like somebody was transitioning to a trans male, we need to be careful about how much we use, and we need to monitor levels, not because we're targeting them, but because we want to make sure we're staying in a safe zone.
But if women are taking female doses, could those things also happen to them? Or is that only if they're in a dose that's higher than in the female range?
Everyone is different. So if we stay within the female range on blood work, it is very unlikely that you would see any kind of an irreversible change. And the nice thing about the changes is they tend to start with things that are noticeable, like getting hair growth, acne on your face, or oily skin. And if you were getting those kinds of symptoms, you would probably decrease the amount you were using anyway, because those are unpalatable symptoms to have. The kind of irreversible changes we're talking about happen when women use too much for too long.
That's great. We've received another question from somebody saying, I'm a woman of Afro-Caribbean descent. I am curious as to how many of the common symptoms associated with menopause may present differently in Black women. And maybe you could also add, we know that there are racial and ethnic differences, what the science tells us based on what we know today. And if you can have any comment related to people who are trans, gender diverse individuals, because there certainly is not enough research in this area.
I mean, you could start by saying there's not enough research in menopause in general, and then talking about how there's really not enough research in specific populations. But if we address the idea of Black women, we can look at studies that were done across the United States, looking at African American women, and we can look at studies that come out of countries that have primarily Black populations. But again, there are big changes and differences in women of Afro-Caribbean descent, women who are currently living in Africa, and women who have dark skin who come from other places in the world. We know that on the whole, and again, on a population level, Black women tend to experience more severe menopausal symptoms that tend to last longer. There are also issues, especially in the United States, where a lot of our research comes from, that talk about access to care. So women who are from marginalized communities, having a mistrust in the healthcare system, or when they do present, having their needs ignored. And so we really don't have that body of evidence to understand specifically if Black women respond in different ways to hormone therapy. In my Black Canadian population, who I see, the biggest issues that I have are that women are able to take hormone therapy. And when they do, they usually respond very similarly, but they do tend to have worse symptoms and symptoms that last longer. There is also much more commonly fibroid growth in women of African descent. And sometimes taking hormone therapy can stimulate fibroid growth. And so these are the kinds of thoughts and nuances that we have to take into consideration.
Gotten a question on endometriosis. Should you be taking both estrogen and progesterone or be taking estrogen only?
Great question. So if you have a uterus, you should be taking combination therapy if you have symptoms of menopause and you need treatment, just like anybody else with a uterus. If you have endometriosis that has been surgically treated and part of your treatment involved taking your uterus out, usually women would be able to, in that circumstance, take estrogen only. But in endometriosis, we have to imagine that this is like the lining of the uterus or the endometrium being implanted elsewhere in the pelvis. And though we try and get most of it out when we do surgery, we can't always tell where it is or get all of it out safely. So if you're giving estrogen to someone who doesn't have a uterus anymore, but still has that lining of the uterus implanted in their pelvis, you can imagine that the same risks apply as somebody who still has a uterus. And so we have studies showing higher rates of cancer in those endometriosis implants in women who have taken estrogen alone hormone therapy, or flares of endometriosis even once they're in menopause and their uterus has been removed once they start hormone therapy. So it is my practice, if you have deeply infiltrating endometriosis, to give combination therapy with estrogen and a progestogen, even if you've had your uterus removed.
So complex when people don't have a simple, straightforward path. We've gotten some questions here related to people not being able to get the help they need. Where can I go when my family doctor dismisses or minimizes my symptoms? Where can I find specialized services to find a physician who specializes in menopause? Am I allowed to ask my family doctor to outsource me to an expert? So this is all under that umbrella of I'm trying to get help, but I really can't find somebody who's great to support me on this journey.
And this is so unfortunate, right? Like, this is the failure of our healthcare system and the marginalization of women, and especially aging women. This is discrimination. This is ageism. This is a social justice issue. And on the other side of the coin, there is also a paucity or too few doctors who specialize in menopause management. So even if you do get connected to the right people, like myself, you might wait 2.5 years suffering so that you can see somebody like me. And so this really comes to the root of the problem, that we have a supply and demand problem here. If your family doctor or nurse practitioner, your primary care physician, is not able to give you an evidence-based treatment and answer, then it does end up being appropriate for you to be seen elsewhere. You can get referred to a menopause specialist, and there are specialists across Canada, of course, with long wait lists, or you can ask the Menopause Foundation of Canada to help you advocate for yourself and give you information about where the closest menopause specialist is to you. You can use websites that are listed on the Menopause Foundation of Canada's website, like the MQ6, to have a validated evaluation of your symptoms that you can show your physician to say, I actually meet criteria or I qualify, and it's recommended that you treat me for these symptoms. And then there are always going to be these private clinics. Coven is one of them. So I'm saying this with some bias, but that there are clinics that are popping up both virtually and in person, which allow women to pay for access to care, which sucks because it would be nice if your access to care was all covered by your provincial insurance. And yet for some women, the need for rapid access, evidence-based, expertise, and multidisciplinary care is worth paying for. And the Menopause Foundation of Canada has recently put out a document showing you how you can evaluate whether a clinic you're thinking about going to is a good one or not. Is it evidence-based? Is it doing things that are sketchy? Is it taking advantage of you? Or is this simply another route for you to access evidence-based care?
You're so right, Dr. Jacobson. We do have a supply and demand issue. There are 10 million women in Canada over the age of 40, and we are being denied access to high quality menopause care and treatment. So on our website, we do have all kinds of free resources to help you have a good conversation with your healthcare provider. We link to all of the evidence-based sources of information so you can take that into your provider. And, women should not have to pay for menopause care. We're really grateful that there are now options available to women, but that is not filling the huge chasm, the gap in care. So we still have to really advocate and push for every healthcare provider that touches a midlife woman needs to understand menopause. So that's great there. Let's keep moving on here to other questions. Question about family physician wanting to only allow a woman to stay on hormone therapy for 5 years. Is that true?
I mean, the word allow, right? That's the problem unto itself. We've talked about agency, but every decision you make as an adult woman should be with all of the informed consent and risk and benefit information available to you. So there used to be a sort of thought that hormone therapy should be used at the lowest dose for the shortest amount of time. And after 5 years, because the risk of breast cancer is slightly increased for women taking most types of hormone therapy after 5 years, that at that point, women should come off of it. But what if they're still symptomatic? Then you haven't really solved that problem. You now have a woman who is still symptomatic and is now being denied therapy. So the newer approach, and when I say new, it's really the last 10 years or so, is to say that care should be individualized. And the guidelines tell us that women should be offered treatment for menopause for as long as they need it for symptom relief. Now, if your symptoms were really well controlled, you may not know if you needed it anymore. So it is reasonable to try and come off of your hormone therapy at defined intervals on your own terms when you feel ready to say, do I still need my hormone therapy or my non-hormonal medication? Or am I past the point of my symptoms being disruptive? But if you continue to have symptoms, it is reasonable to continue on the hormone therapy. And our job as physicians is to try and minimize the risk from your hormone therapy. So as you get older, when you're at more of a risk for a blood clot in the legs or the lungs, this might become a time where we want to lower your dose to the lowest dose that works for you and give you hormone therapy for the skin if you can afford it. But if you are limited by finances or you don't like taking your hormones through the skin, there is no hard and fast rule that you must do something or something else. Your care should be individualized. I feel like a broken record here.
Yes, care should be individualized, and we're getting more information all the time. And I certainly know many women who want to be on hormone therapy for as long as they can be because it's protecting their bones. And of course, all of the local vaginal hormonal therapy options available that can be taken for life. So we've got another question here. What are the risks and benefits of starting hormone therapy more than 10 years after your last menstrual period if someone is in good health?
So we're talking about systemic hormone therapy here, because again, to reiterate, you can start vaginal therapy at any time. It doesn't matter how far away you are from your final period. If you are more than 10 years, you fall into the category of women who were studied, who had more cardiac events, so more heart attacks, more strokes, more blood clots when they were started on hormone therapy, if they were into their 60s or 70s or more than 10 years from their final period. So this has led to that window of opportunity hypothesis where the idea is the sooner you start it to your menopause, the safer it is to take and to continue taking. But if you are in a position where you didn't have access, you're still bothered by symptoms, and now you want to start hormone therapy, it would be appropriate to do a kind of cardiovascular assessment, whether that's going to be by using a risk calculator or checking blood levels of something called a lipoprotein little a and a cholesterol level, or doing some advanced imaging like a coronary artery calcium score or a carotid intimal thickness. These are ways that we can assess what your plaque formation is and help you make a, again, individualized and appropriate decision about whether it's worth starting therapy or whether you want to use a non-hormonal alternative that may not confer the same risk of starting therapy.
I think there's never been a better time to be in menopause because we do have so many options. And we hear a lot from women in their 60s and 70s who say, I still have these hot flashes. I've never been on hormone therapy. What can I do? And now we have these new non-hormonal options that target the center of the brain. So it is quite exciting that we can do all of that. And we also have all of the lifestyle options. Question here, is high blood pressure related to perimenopause?
It can be. So perimenopause is actually a time where you will go through the most abrupt physiologic changes when it comes to your cholesterol, your blood pressure, your bone density than any other time in your life. So not only is it an opportunity to live your healthiest, so making those healthiest decisions about exercise and alcohol and smoking, but also about being quite aggressive of managing your cholesterol and your cardiac risk factors. Now I've lost my track on what the actual question was. High blood pressure. So this is a time where you are most likely to develop higher blood pressure, but there may be something that is contributing to your high blood pressure. It could be stress. It could be your distress over your hot flashes, in which case hormone therapy may actually be very helpful. And certain types of hormone therapy, like the ones that go through the skin, can actually help to lower blood pressure to some degree. Certain types of progestogens can act as a diuretic. So again, we want to be individualized. Birth control does tend to increase blood pressure by about 5 points on the systolic, but hormone therapy does not have the same impact. And you want to actually treat your blood pressure because this is the time where it will lead to the worst cardiometabolic outcomes.
Mm-hmm. Yeah, it's very important for us to recognize that we have to see this stage of life as a health transition and one that we should pay attention to. So gives us that opportunity to do that.
We do this in pregnancy, right? Most women, if they're smoking or they're not living their healthiest life or they're drinking alcohol, pregnancy is a time where they're very ready to change their lifestyle. I would urge women to treat perimenopause as the same kind of an opportunity to take a look at your life and say, what kind of decisions I've been making that I've gotten away with, but now my health is more at risk, and this is my opportunity to live my healthiest and longest life possible.
Mm-hmm. So well said. We're going to end with a provocative statement that we actually received, not necessarily a question, but we can get your reaction to it. Someone wrote in, we often hear about how to manage or fix our menopause transition in order to, for example, reduce physical symptoms or keep looking young or keep our vaginas moist. Hardly ever do I hear about embracing the change. Of course, we don't want to suffer through unmanageable symptoms and accept that we are becoming mature women and sages who are not the same persons as before. Menopause does not have to be fixed, but should be embraced, accepted, and celebrated. What are your thoughts on that?
So I love that statement. And yet I don't think that they are mutually exclusive. Like, I think that you can and should treat symptoms that bother you. Certainly don't treat things that don't bother you. And at the same time, embrace, like we started with, the changes that you're going through with regards to your wisdom and your not giving a you know what anymore, and your excitement about the things that you don't need to worry about anymore. And this transition, we definitely need to reframe a fear of getting older, but shouldn't we be encouraged to make choices, regardless of how other people interpret them, that make us feel and live our best lives? You know, whether it's dyeing your hair because you like being blonde or dyeing your hair because you want to cover the gray, at the end of the day, you do what works for you because it makes you feel your best. And so I think that that provocative statement, which is a great one, is not different than all of the things that we've been talking about.
I so agree. It's not mutually exclusive. You know, just because you may be treating your symptoms, taking hormone therapy or non-hormonal therapy options, or doing all kinds of things that are lifestyle related or cognitive behavioral therapy, you are still going through menopause. You are still changing. Your brain is being rewired. So, yes, we just need to lean into this wonderful time of life. And, you know, we hear at the Menopause Foundation of Canada from women who are struggling. And it's heartbreaking to know that women can struggle for so long without the help that they need. And that's why we're so very grateful to you, Dr. Jacobson, for sharing your immense, deep expertise with us this evening. I wish women had access to a doctor like you all the time, but I think you've provided us with good advice and with inspiration to really take care of ourselves, to look after our health. Thank you to everybody who joined us for this version of Menopause Illuminated. We really appreciated your engagement. We're getting lots of love and emojis coming up here, so we really appreciate that. Don't forget to visit the Menopause Foundation of Canada.ca for all of the free resources that are there. And we'll end where we began. This is a wonderful stage of life. Knowledge is power. We hope you learned something tonight. Please share this with the people that you care about, and let's work together to change the conversation on menopause and to make sure that women get the care and support that they so rightly deserve. Thank you so much. Thank you, Dr. Jacobson.
Thank you, Janet. You're wonderful.